So hemiplegia, so as the name suggests, it's hemiplegia. Hemi means one half of the body, and plegia from the ancient Greek term. It means to strike. That means hemiplegia indicates to strike, or one half of the body is striken. And to define hemiplegia, it's a paralysis of one side of the body due to pyramidal tract lesion at any point from its origin in the cerebral cortex down to the spinal cord segments, especially C5. So it's a paralysis of one side of the body, hemiplegia, and it's occurring due to a pyramidal tract lesion. That means a lesion in the pyramidal tract. What is a pyramidal tract? You can see in the picture the nervous tract that originates from the motor cortex, and it runs down through the internal capsule and to the brainstem, especially through the pyramids of the medulla, and that's why it's called as the pyramidal tract. And it runs down to the lower part of medulla, where it divides into lateral corticospinal tract and anterior corticospinal tract. That means 80% of the corticospinal tract, which after at the level of medulla, lower part of the medulla, it crosses to the opposite side and runs down to the anterior horn cell of the spinal cord. That is called as lateral corticospinal tract. And 20% of those from the level of lower part of medulla, it runs down to the same side. That is called as ipsilateral, and it is anterior corticospinal tract. So lateral is contralateral, and anterior is ipsilateral. And any lesion occurring anywhere in this pathway till the anterior horn cell, starting from the primary motor cortex, any lesion occurring anywhere, it can lead to paralysis of one side of the body, and that is called as hemiplegia. Now, depending on the area or extent of paralysis, again, similar terminologies or similar conditions are there, like hemiplegia, that is quadriplegia or tetraplegia. As the name says, quadri means it's a paralysis caused by illness or injury that results in the partial or total loss of use of all four limbs. That is quadri, all four limbs and the torso or the trunk. So that is called as quadriplegia. There is a total loss or a partial loss of use of all four limbs, as both upper limb and lower limbs, along with the torso. And the loss is usually sensory, either sensory and motor, and it may be flaccid or spastic paralysis depending on the motor neuron lesion involved. That is upper motor neuron and lower motor neuron. If it is upper motor neuron, it is spastic, and if it is lower motor neuron, it will be flaccid type. The muscles will be flaccid. Otherwise, the muscles in upper motor neuron, the muscles will be spastic. Then loss of impairment in controlling bowel and bladder, that is autonomic functions. Also sexual functions, digestion, breathing, etc. are also affected. In some cases, autonomic nervous system is involved. And damage to the brain or spinal cord at the higher level, that is C1 to C7, it can induce quadriplegia or tetraplegia. Similar condition in which the sensory function of the lower extremities, motor and sensory function both of the lower extremities is involved, it is called as paraplegia. So in paraplegia, the lower extremities are involved, both the motor and sensory function are affected. It can be due to spinal cord injury, or maybe due to accidents or trauma or something, or infections, then or congenital conditions such as spina bifida. It's a condition, spina bifida, when there is it's a neural tube defect actually occurring in the embryonic stage itself. The spine vertebral column is not properly formed, and there is a gap in the vertebral column through which the meninges can protrude outside, and it can cause paraplegia. And usually thoracic, lumbar and sacral regions are often affected. Then monoplegia is another condition, as the name suggests. It's a single limb is involved. Paralysis of a single limb, usually an arm, etc. Frequently associated with cerebral palsy. I will just go through the causes of paralysis. That is, in case of hemiplegia, a stroke is a reason for hemiplegia, stroke or a cerebrovascular accident. So we have learned about stroke. So when there's a loss of blood supply towards a particular area in the brain, it causes destruction of the brain cells and subsequent weakness in one half of the body, along with other symptoms. That is a stroke syndrome, and hemiplegia is one of them. Then paraplegia, tetraplegia, or quadriplegia. So all these are occurred due to trauma, mainly due to trauma is one major factor. That can include any road accidents or any falls or any assaults or attacks or assaults or any gunshots and sports injuries, etc. So many kinds of trauma are a reason in which the brain or the higher centers of the brain or even the spinal cord is injured. Also, a disease called as poliomyelitis. Poliomyelitis, it attacks the central nervous system and it can cause paraplegia or tetraplegia. Usually, flaccid paralysis is seen in poliomyelitis of the forelimbs, especially the lower limbs are affected than the upper limbs. Congenital disorders also are involved as a reason for paralysis. And muscular dystrophy is one reason. Muscular dystrophy, there is a progressive weakness and loss of muscle mass in the body. And in multiple sclerosis, it is an autoimmune condition where there is a demyelinating process is going on. That means the nerves loses its myelin sheaths and proper communication is hampered. And spina bifida, as I explained, is a neural tube disorder where the vertebral column, there's a defect in the vertebral column formation, and through the gap, the meninges, it protrudes out. Example, meningomyelocele, spina bifida, occulta, etc. are the examples of spina bifida. So all these are the reasons for paralysis. Also, injuries to the pyramidal tract, that is above the medulla, the lesions that occurs in the upper part of the medulla or above it, it generally causes contralateral hemiparesis, since 80% of the tract it runs to the opposite side and continues down as lateral corticospinal tract. I have explained it earlier. And the weakness is seen in the opposite side of the injury. If the injury is in the right side, the weakness will be on the left side. And injuries at the lower part of medulla, spinal cord and the peripheral nerves, it results in ipsilateral hemiparesis, since most of the or 20% of the corticospinal tract, that is anterior corticospinal tract, it runs down to the same side, that is the ipsilateral side, and it causes weakness in the same side if the lesions is below the medulla and spinal cord or the peripheral nerves. Now we will have a quick look on the causes of hemiplegia. We have already discussed these points in the previous chapters of stroke, thrombus or atherosclerosis or whatever. The main cause, it is a vascular cause. It can be thrombotic, embolic, and even hemorrhagic. And then the thrombotic cause, it can be from three reasons. That is, vessel wall diseases can produce thrombus. Any blood disorders like platelet disorders or hypercoagulability, it can produce thrombus. And circulation diseases, if there is any obstruction to circulation, it can also produce thrombus. And when we come to the embolic causes, the source of emboli may be, the embolus may be, it can be from the heart or any distal vessels of the limb. Then also rare sources also from the lungs and even from the bones. Sometimes emboli can enter the circulation and produces ischemia. Hemorrhagic causes, I already discussed intracerebral that is into the brain, and subarachnoid, subdural or extradural, that is around the brain. Mostly it is intracerebral and subarachnoid, and rarely subdural or extradural hemorrhage also some seen sometimes. So these are the main reasons for hemiplegia under the heading vascular causes. So the first one was vascular causes. Second one is infective causes, which includes encephalitis, that is infection or inflammation of the brain. It can be due to viral or bacterial causes. Any kind of viral or bacterial, it can affect the brain and produce encephalitis. Then meningitis, it's again the inflammation of the meninges or the covering of the brain. Then a brain abscess, it can produce a paralysis by destruction of a part of the brain. Again, neoplastic reasons, glioma and meningioma, these are the most common reasons for paralysis. Glioma, it's cancer that occurs to the glial cells. Glial cells you will be knowing, it's the glue to the nervous system. It connects the nerves together, nervous tissues together. So glioma, it's of three types, that is astrocytes, ependymal cells, oligodendrons. So depending on that, astrocytoma, ependymoma, then oligodendroglioma. So all these can occur. Then meningioma, again, it's a benign cancer of the meninges. Glioma is usually malignant, and sometimes it is benign also. Then demyelinating disorders like multiple sclerosis, where the myelin sheath is destructed. Then traumatic cases, which include cerebral lacerations or any injuries to the brain. Then congenital causes like cerebral palsy. Then psychological causes like parasomnia, it's a sleep disorder, and in this there is a condition called as sleep paralysis that occurs in parasomnia. It is a temporary condition where the person will be conscious but he will be unable to move or work for a few minutes. So these are the reasons of hemiplegia. Now when we come to symptoms of hemiplegia, the basic symptoms that are similar to what we discussed in stroke, that there is sudden numbness or weakness in the face, arm, leg of one side of the body, and there is a sudden severe headache, difficulty seeing in one or both eyes. Then there is confusion, trouble in speaking or understanding. There is dizziness and loss of balance and coordination depending on the area which is involved. And if the extrapyramidal area, there is any part other than the pyramidal tracts, there is extrapyramidal, it basically includes the basal ganglia, thalamus, cerebellum. So all these areas, if any lesion is present in this, that area, the extrapyramidal symptoms can be seen. So there may be hypertonia, rigidity, and muscle power is maintained, but there is bradykinesia. That means there is inability to initiate or carry out movements despite the presence of adequate strength. That is, the patient will lose the spontaneous movement, the capacity to move spontaneously. Then involuntary movements or tremors will be present. Then postural instability is there. The person can't maintain his posture. For example, if we are pushing a person, usually what happens is that we try to balance with our legs, but here what happens is that the person falls down directly as soon as we push. Then other symptoms like headache, vomiting, altered consciousness, and seizures, bladder and bowel, depending on the autonomic system involvement. So all these are seen as extrapyramidal symptoms. So again, on clinical examination, we can divide the symptoms basis on two factors, that is the presence of lesion, whether it is on the upper motor neuron pathway or on the lower motor neuron pathway, And both of these lesions, both of these kinds of lesions have specific patterns. So we can understand clinically by examining or taking the reflexes or other examinations, we can clearly distinguish whether the lesion is in the lower motor neuron pathway or in the upper motor neuron pathway in case of a hemiplegia patient. So before going to the symptoms of upper motor neuron lesions and lower motor neuron lesions, I'll just give a basic idea of what is upper motor neuron and what is lower motor neuron. So upper motor neuron, it is almost most of the pyramidal tract. You can see the pyramidal fibers. It starts from the cerebral cortex, the corona radiata, and comes through the internal capsule, and in the midbrain, the crus cerebri of the midbrain. Then the pontine or the pons, through the pons, pontine longitudinal fibers. Then it comes down to the pyramids of the medulla, that is number 5. And sixth, it is the pyramidal decussation happens in the lower part of medulla, and it divides into lateral corticospinal tract and anterior corticospinal tract, and it ends in the anterior horn cells or ventral horn cells of the spinal cord. So this is the upper motor neuron tract, and the lesions occurring in this pathway have a specific type of symptoms which I will be explaining soon. Now the lower motor neuron unit and the cell body, it is the anterior horn. You can see the anterior horn cells in that purple color. These are the place where, that's the place where the anterior horn cells are originating, which is the cell body of the lower motor neuron. So the upper motor neuron, from the cortex, it connects to the ventral horn or the anterior horn, and from there the cell body of the lower motor neuron, it starts. So you can see that in the picture, and the axons of the from the cell body, it's the anterior root, or what we call as the spinal nerves. The spinal nerves begin from the anterior horn cells, and it ends in the axon terminals. The axon terminal is ending in the muscle fibers of the skeletal muscles, and that joining place is called as a neuromuscular junction, or a myoneural junction, or a motor end plate. It is also called by similar names. And you can see the how the axon terminals, they are winding up the muscle fibers and are connected by means of neuromuscular, and this is called as a neuromuscular junction. And the whole muscle cells, it works as a unit. It's called as a motor unit. The action potential is generated by it. And the effector, it cells, that is the skeletal muscle. The whole effect is seen in the skeletal muscles. So any lesion in the lower motor neuron, it can affect the skeletal muscles depending on the area it is supplied. So in this diagram, it will be a bit more clear regarding the pathways of upper motor neuron and lower motor neuron. So in the blue, they have shown it, the upper motor neuron and the lesions, any lesions, for example, cerebral infection is one of the examples they have given. If it is occurring in the upper motor neuron, a specific kind of symptoms will be found. And these lesions can occur anywhere starting from the cerebral cortex to the spinal cord, end of the spinal cord, that is shown in blue. So any lesions occurring in anywhere in these levels, it can produce symptoms of hemiplegia, quadriplegia, or paraplegia. So usually at the neck level or the cervical level, from the cerebral cortex, if any lesion occurs, it can cause hemiplegia as well as quadriplegia, etc. And below that, at the spinal cord level, it can cause paraplegia. And you can see the green lines that is emerging from the blue line. That is the starting point is the anterior horn cell to the skeletal muscles all over the body. So these are the lower motor neurons, or the spinal nerves, or the peripheral nerves. So any lesion in this green part, that will cause lower motor neuron symptoms. So now we will go through the upper motor neuron lesions. The first point, it is the contralateral and ipsilateral paralysis. So in human lesion, both contralateral and ipsilateral paralysis can be seen. That means if the lesions is found, it's above the pyramidal decussation in the medulla, it would cause the spasticity or weakness of the muscles of the left half of the body if the lesion is occurring in the right corticospinal tract before the pyramidal decussation. But in case of UML lesion, caudal means below the decussation, it will cause symptoms ipsilateral to the same to the site of the lesion. That is, left-sided lesion of the corticospinal tract in the spinal cord. It will cause left-sided weakness and spasticity. Usually ipsilateral paralysis is seen in the lesions of the spinal cord because already the tract has decussated to the opposite sides before the in the lower part of the medulla itself. And the second point is diffuse weakness of muscle group. So usually in upper motor neuron lesion, a large area of muscle groups is involved, and even the whole limb is getting paralyzed, and the muscle atrophy. Atrophy means there is a loss of muscle bulk and weakness is present, and this might be there present in a group of muscles. Whereas in LML lesion, the specific skeletal muscle weakness can be seen. Then hyperreflexia means the reflex actions will be hyper or exaggerated. It is seen exaggerated, especially the deep tendon reflexes. And these exaggerated reflexes, it is usually seen it is greater compared to, it is greater in the extensors of the lower limb, that is extensor group of muscles in the lower limb, or those group of muscles which helps your leg to extend, the knee as well as the ankle to extend, and flexors of the upper limb, that means the flexor group of muscles of the upper limb which helps your upper limb to get flexed. So this hyperreflexia will be comparatively more in this group of muscles. And the superficial reflexes. So reflexes are of two types, that is deep tendon reflexes and superficial reflexes. Deep tendon reflexes, I have already mentioned, it is hyperreflexia, whereas superficial reflexes, it is absent, usually it's mild or very mild or absent. That means there are reflexes like abdominal reflex and cremasteric reflex, etc. These are found to be absent because these are coming from the higher centers and not from the spinal cord. Then extensor plantar reflex, it's one type of superficial reflex, but a sign called as Babinski sign, it is present in upper motor neuron lesion. So you can see when you are striking your sole with a pointed object in the direction as shown laterally down from the sole to the big toe laterally, we are stroking with a pointed object. You can see there is a dorsiflexion of the great toe with or without fanning of the other toes, and withdrawal of the leg. This is seen in plantar stimulation in patients with pyramidal tract dysfunctions. Normally, when you are striking with a sharp object in your sole, or drawing with a sharp object in your sole, the normal plantar response is seen in the first image. There is flexion of the toes. Your foot or the toes get flexed. That's the normal plantar response. In extensor plantar response or Babinski sign, what happens is that the great toe, your great toe will dorsiflex or extend, and other toes will get fanned. Fanning of the toes may or may not be present, fanning may or may not be present, but the great toe gets extended or dorsiflexed, and also there will be withdrawal of the leg. So this is very important sign in upper motor neuron, that is Babinski's sign. The next sign is the clonus. Clonus is a muscular spasm. It is repeated and rhythmic contractions of muscles, especially the antagonistic muscles. Antagonistic muscles means the muscles of the opposite side. That means agonist and antagonist. So when you are when we are putting the agonist muscle into action, the antagonic muscles will get rhythmic contractions. That is called as clonus. Then hypertonia or spasticity. The tone of the muscle is hyper, means it is spastic. There is an increased tone of skeletal muscle is seen in the upper motor neuron lesion. Now we'll come to the lower motor neuron lesions. First one is it's usually ipsilateral or the same side. Second point is atrophy. There is a decreased muscle bulk and weakness is also present. Then fasciculations is another sign. That is muscle twitch. Fasciculations are muscle twitch or vibrations. They are visible spontaneous contractions. It's visible usually, and spontaneous contractions involving small groups of muscle fibers. So these are visible and occurs in groups of muscle fibers, small muscle twitches or contractions. Fibrillations, these are muscular twitching, again a similar kind of muscular twitching, but it is a bit minute than the fasciculations. It involves individual muscles, usually individual muscle fibers, which acts without coordination, that is fibrillation. So both are seen in lower motor neuron lesions. Then hypotonia, that is the muscle tone becomes flaccid. In upper motor neuron it is spastic or rigid. Here it is flaccid or hypotonia. Then the reflexes, it is hyporeflexia. In upper motor neuron lesion it was hyperreflexia, then here it is diminished. So hyporeflexia, since the nerve is affected, since the nerve supplying the specific skeletal muscle is affected, it affects the reflexes. You will not get the proper reflexes, that is hyporeflexia. Now I'll just explain why a superficial reflex is lost in both upper motor neuron and a lower motor neuron lesion. So in a lower motor neuron lesion, the motor supply to the muscle, it is via the anterior horn cell, as you have seen the pathway. The motor supply is lost here, since there is a lesion in the spinal nerve or this peripheral nerve. And hence the muscle can't respond to the given sensory stimulus. That means superficial reflexes are usually sensory stimuluses. So we are scratching the abdomen or the cremasteric area or the cornea. So these are all sensory stimuluses. The sensory stimulus will reach, but the motor supply, motor action cannot respond. The muscle cannot respond to the sensory stimulus. And that's the reason why it is absent in the lower motor neuron lesion. In upper motor neuron lesion, the specialty of superficial reflex usually it is that it is a polysynaptic reflex. That means it has different synapses up to the brain from its origin. One in the spinal cord and then in the brain. It's a polysynaptic reflex. So deep tendon is usually monosynaptic, but here it is polysynaptic. The sensation has to travel to the spinal cord and then in the brainstem and to the cortex. So the integration of these sensory stimulus, it occurs in the brainstem and then they are transmitted into the cortex. The cortex in turn sends excitatory motor impulses down via the corticobulbar tracts to the respective nucleuses in the brainstem, corticobulbar to the brainstem or pons or medulla, and the effect is usually achieved. But what happens is that here, I'll say an example, a corneal reflex. You know, a corneal reflex means the eye blinks when we touch the cornea with a piece of cotton or something. The eye blinks, that's the corneal reflex. So when the cornea is stimulated, the impulses are carried by the fifth cranial nerve, usually the trigeminal nerve, and to the center in pons, and from the cortex, the initiation of motor action comes, and the efferent or the motor action of blinking is made by the facial nerve. It's transmitted by the facial nerve. So any obstruction in the center, around the cortex or the upper motor neuron pathway, it can cause cessation of this action. So the trigeminal nerve carries the sensory stimulus to the spinal cord up to the pons and then sends motor supply by the facial nerve, which is in turn regulated by the cortex. And any damage or interruption to the connection between brain and spinal cord, it leads to the loss of superficial reflexes.